we talked about yesterday. Being able to separate your femur from your pelvis in rotation. So if you don't have that separation, what ends up happening, we end up funneling too much rotation into the lumbar spine, which is really, really common. We need to be able to separate our thoracic spine from our rib cage, which means we need to have good motion between our costotransverse, our costovertebral articulations, our thoracic facet joints. It's really important that, like, if we tell our patients to sit up, that they don't just sit up with everything. If you have really good separation from your rib cage and your thoracic spine, this stays down as you upright your thoracic spine. But most people, if you just tell them to sit up straight, they just go like this. Posteriorly compress their spine, they lose all their anterior stability. We worked a lot with this today and yesterday. So when we need to work on separating the shoulder blade from the humerus, everything we did yesterday on the side when we were doing those mobilizations, that is like amazing for that. And then we just showed you another really good way to do that from this position. And then being able to have motion at your CT junction. Therefore, like if you look in golf, this is maximum what rotation? This is maximum left cervical rotation as you're going to find in any other sport. No one really thinks about it, but so if you have any hiccup in your CT junction or in the soft tissues around that area, you automatically are now shortening your ability to keep your head in the same position, which is like a hallmark of golf. Like we want to be able to keep our head. Like the greats, what you'll see, their heads don't rise up much. They will rotate just to get more elasticity in their swing. But for the everyday good recreational golfers, a lot of times they're able to keep their head relatively still. The other thing too, we want to, if you don't have that good rotation there, what you end up doing is you end up laterally bending your neck. Even in, not in golf, in everyday life, if you have good y-axis rotation, you'll just spin and rotate your neck like this. Your patients who have neck problems and block segments, they do this. So they have to have like a component of lateral bending with their rotation. So you can see here, as he takes the club back here, see how his foot he stays on that tripod? Probably 95% of this room, if I gave you a golf club, your foot's going to come up into supination here. And you're going to lose your knee into a varus position. The top 1,000 golfers in the world, they will keep this all in the same position, even at the end of their backswing. And that is the key to turning on your hip muscles. So, but the subtalar joint has to have movement there. You have to be able to keep your foot in a tripod position as your tibia externally rotates. If you don't, then this foot will have to come up. So like we said before, like with the golfers, guys like Sam Snead, when they were struggling, they'd play around a golf barefoot, and then like that was a lot of times would help them be able to feel the ground and earth the ground and screw their feet into the ground better in the golf swing. Here's a good picture of, here's Nick Faldo. So you see here in the backswing at this point, he's probably got 95% of his weight on his right foot right now. And notice how he keeps his foot and his knee all in this centrated position. So what's he doing? He's essentially creating stretch here. So if you were to do this to yourself right now, what you'd feel if you did it right, you feel like someone's like turning on your external rotators and your abductors of your pelvis. That's the feeling you want to feel in the backswing. And then I was just going to show you, so if you don't have the good subtalar joint motion on the left foot, then you have to escape. And I'll show you there's a couple of the reasons why. This is Ernie Elf. So watch his left foot as he swings through here. Great, he's got a great golf swing, by the way. So see how he could actually have more torque if he kept that foot down. So two things, I don't know his story, but either we could work with the motion and the control on that. The other thing is this may long term, like we call this on a right-handed golfer, the golfer's left hip, which a lot of times that's the one that ends up getting replaced, like on Jack Nicklaus and a lot of our great golfers. So there's a chance that this is a way that he can alleviate that torque. He's found a way to kind of get rid of that, all that torque that's in his hip. It's like A-Rod, Alex Rodriguez, who minus the steroids, he's probably like the best all-around baseball player that ever played, if that hadn't tainted his career. And he's one of the best all-time hitters, and you'll see like he classically like just stayed in the hitting zone forever. And it's what allowed him to create so much torque, but it ended up destroying his hip joint. So he ended up, having all kinds of labor repairs and stuff like that. So it's kind of the blessing and the curse. So, but like in the golf swing here, it'd be interesting to see like if we could work with getting better disassociation there to where he wouldn't have to do that, because it definitely does rob him of some of his power. You did this today, so this is a great way to start to work on the subtalar joint, this position here. So keep the first metatarsal down, and then they can start to work on external tibial torsion. Tripod, which we still got to go over today. So whenever you need to work with the foot specifically, I definitely think this is probably the the best position of tripod to work with. Or either that or the one we just finished with. This is also an amazing position for your groin. Like to get you, if you ever have somebody who's got tightness in the groin, this is like the go-to. We'll go over this here in a second. Then you can see in the golf swing, like we were talking about before, like in the backswing here, this is maximum right hip internal rotation. And so we need separation between our femur and our acetabulum, and if we can do that well, then we'll spare our spine in the golf swing. Most everyday people, when they swing a golf club, there's way too much force and load going through the lumbar spine because they're not able to allow their hips to create that rotation that we were talking about before. Big old ipsilateral pattern. See how the rib cage and the pelvis moving together? The reason I got Hogan here, he had an amazing ability to not really use much of the X factor. Like he was able to like literally rotate everything together, like in a real pure DNS way. So see how his rib cage and pelvis, look at how much pelvic rotation he has there. It's bizarre.
It almost looks like he's sitting backwards.
Yeah. So from a DNS standpoint, it's actually like he'd be like our poster child for golf because he's able to do that. A lot of people don't have the hip mobility to be able to do that. Like I wonder if he had maybe like a little bit of leg hypertrophy just to have that kind of rotation there. Like a lot of our really, really, really good Olympic weightlifters, they've had like slip femoral epiphysis or leg hypertrophy, and it's like it was a curse when they were younger, but then it almost allows them to have like a ton of hip flexibility as they age. Or like in baseball, like a lot of our Major League Baseball pitchers, they have humeral retroversion. So not the torsion that occurs from throwing a baseball that we all know when the growth plates are open, but besides that, like they didn't have ideal development, so they have like too much torsion in their humerus as it enters their shoulder. And when you have retroversion in your shoulder, just like you have it in your hip, it gives you more of what motion? External rotation. It gives you excessive amounts of external rotation. And you can see how for baseball that's a huge benefit. So the developmental sequencing might not have been ideal. You might have been left with something we would say in this room is not ideal. However, sometimes it ends up helping you in whatever it is you're going to do. Again, the gold standard to see whether or not your patient tomorrow needs surgery or not is run them through everything we ran through this weekend and do that for 3 weeks and do an amazing job with it and then see where it's at. So it really, I pay very, very little attention to the size of the tear. Like the severity of the MRI, I don't really care. The trial of care is what tells me whether or not they need surgery or not. So, and that's true anywhere in the body, by the way. So the most common one we see is obviously the cam, where they add on bone to the femoral side. Pincers, when they add on bone to the pelvis or acetabular side. A lot of times they have the fleas and the ticks, and we got a little bit of both. But I've been fortunate enough with the Cardinals. I work with probably the third best guy in the world, David King, for the guy who does this. Number one is Philippon at Hawkins Stedman. He's the one who does almost every professional hip. A new guy, actually at National, Tom Bird. And I have talked to Tom Bird about this. I have never talked to Philippon, but I've talked to obviously the guy I work with, and then Tom's Bird. They believe this starts because of too much rotational sports at a young age. So it's kind of like Wolff's Law. So if you're in in-range hip motion, you're like butting these bones up together. And because of that, you slowly start to add on bone, and it ends up creating a problem.
It's awesome those guys are starting to think about a functional cause.
What's that?
It's awesome he's actually thinking about a functional cause.
Yeah.
It's not
Yeah.
just like how we disappeared.
Yeah. So there's basically, I think, three ways to get there. There's that. There's poor developmental kinesiology, like we talked about in that opening lecture. And then there's just like the genetics of your hip. Like sometimes like that plays a factor in it also. So yeah, it could be a combination of all three of those things.
Say, Brett?
What's that?
I didn't understand what you said.
Just that they're thinking more functionally, even though they're surgeons.
Oh, okay.
Yep. So anyways, I told because then last year I was with them every day, and I would say, I was like, yeah, you know those people. I knew they were going to surgery, and I would just send them back to you. Like I would say, you got to say your worst, because you're going to surgery. I know it for a fact. And why would we wait another 3 to 6 months and stall out when you need to be, And so he was laughing so hard, but they don't have the benefit of a trial of care. They're literally stuck with a little bit of a exam finding on the table, and then whatever the MRI says, and that's limiting big time. If I took my trial of care versus the MRI, I would take my trial of care 1,000,000 times ahead of that. So, and then that's not to say an MRI is not important. We're obviously ordering MRIs daily for things, but it's always to kind of confirm and see what's not getting better. So I think too, educating your patients on that's also tricky but helpful.